A perfect afternoon to everyone present here. I'm Prerna, a second year MHA student at Prasanna School of Public Health, MAHE, Manipal, India. It is my honor to welcome you all to benefit from the 14th webinar organized by the Manipal Health Literacy Unit, which is MHLU, to attend this free webinar on health literacy for healthcare providers, researchers, policymakers, industry, academia, and the public. Before introducing our webinar speaker for today, I'd like to make an essential request to participants to kindly mute their cell phones and the mic. You may post any queries, questions during this session through the chat box. We'll be addressing a few selected questions considering the time limit. So, in today's webinar, we will hear our experts' insights on cervical cancer screening, health literacy in Asia, Africa, and Europe, and landscape of youth mental health at SCARF. Please note, each speaker will be sharing their insights for 15 minutes. Ladies and gentlemen, please allow me to introduce our speakers to discuss the first topic. Dr. Jaap Koot, who is a medical doctor registered in the Netherlands, specializing in global health and tropical medicine, and holds a master's degree in business administration. He is a senior staff member in the Department of Social Medicine Global Health Unit and the retired Dean of Global Health Program at the University Medical Center Groningen, UNCG, Netherlands. As a research coordinator, he leads the EU-funded projects focusing on non-communicable diseases in Southeast Asia and cervical cancer screening uptake in Africa and Europe. His research emphasizes community-based mobilization, engagement, and health literacy. Dr. Koot has also researched health literacy competencies in Europe's aging population, IROHLA. He serves as an advisor to WHO, the World Bank, and the Global Fund, contributing to health systems strengthening in low and middle income countries. And with him, we have Dr. Arati P. Rao, Associate Professor and Head of Department of Global Public Health Policy and Governance at MAHE, Manipal. Please join me in welcoming Dr. Jaap Koot and Dr. Arati P. Rao. Over to you.
Thank you very much for your introduction, and let me start by sharing my screen. Hopefully it works. Yes. So Dr. Ati Rao and myself, we have been working together in a project called Prescript Tech that's on cervical cancer screening, improving cervical cancer screening, and we will explain about that and health literacy, how it comes in our project. So maybe to start a bit more on the cervical cancer screening, what it means and what the project was about. We know that cervical cancer screening is still worldwide a huge problem, that 85% of cervical cancers are in low and middle income and countries, and because of the size of the India, 90% of all cervical cancers are from India, so it is still a huge problem. We know that there's nowadays vaccination against HPV, that is the cause of cervical cancer, but it is not yet globally rolled out sufficiently to cover all population. So we still work a lot with screening for cervical cancer, where we test if women have early stages of HPV infection or cervical lesions that can be treated. And that is then what is happening in tertiary prevention. So cervical cancer can be eradicated because it's caused by this HPV infection. And this is a WHO strategy to eliminate cervical cancer. And the quickest way to do it is to combine global HPV vaccination with global screening of women for cervical cancer. Then we can, by 2040, we can already reduce cervical cancer in the world by 50%. So our project was about testing the possibilities of implementing the WHO protocol in one European country, the Slovak Republic, in Bangladesh, India, and Uganda. And in India, MAHE was the lead organization for implementing the project, and in India it's still going on, and Dr. Arti will explain more about that. So our screening was first to do HPV testing, because when you do HPV testing, only the HPV positive women need to have further gynecological examination, and dependent on the prevalence of HPV in the country, it's between 2 and 20% of the women who need to undergo the VIA, which is vaginal examination with acetic acid, where you color the cervix and can decide on the lesions that are there. And with the help of Manipal School of Informatics, we were able to develop an artificial intelligence decision support system. We will not talk about that now. And then next we gave treatment for lesions that we found during the gynecological examination. So that is in short our project. What is crucial in such a project where you want to screen women from the community for having an infection with HPV is the community mobilization. So we did a kind of survey called AWACAN, which is not a health literacy survey, but has many components of health literacy surveys. And we examined, we surveyed 2,800 women in different countries, but we also looked at their husbands, mothers-in-law, and other family members. So we did that before the start of the community mobilization and after the screening. So I want to give you a few figures that are relevant for our discussion about health literacy in the context of cervical cancer. So we found that there are differences between countries that we have been doing the survey about the percentage of women and men and other decision makers, the mothers-in-law, about if they have heard about cervical cancer. So in Bangladesh, Slovak Republic, Uganda, and India, you see the percentage of people who are knowledgeable or have heard about cervical cancer. And you see that in India, the percentage is quite low. And we also did use the score for the knowledge on risk factors. The maximum score that could be achieved if a person is perfectly knowledgeable about the risk of cervical cancer is 11. And then the average score in Bangladesh is 6, 5 in Slovak Republic, 8 in Uganda, but only 2 in India. And the knowledge on symptoms is also different per country, which is higher in Bangladesh and Uganda, but lower in Slovak Republic and India. So you see that globally, the knowledge may differ. The data in India must be further analyzed because we also see a difference between the knowledge levels in urban and rural areas, and also dependent on education level. For example, we analyzed more in detail in Uganda, and there we found that women with lower education level and lower income levels have lower knowledge of cervical cancer. So it is what we know in other health literacy surveys as well, that health literacy is closely related to socioeconomic status. And also for the knowledge on cervical cancer, It is the same pattern that we see. So people who are poorer, have lower education, have lower social standards, often are less well off in terms of knowledge. But as we know, in health literacy, the most important part of health literacy is not only the knowledge, but also the decision making, the critical health literacy. And what we looked at in our context is how much women were able to decide on participating in screening. Were they taking the decision themselves, or were they dependent on others to take the decision? And you see here in 4 different countries the rates of decision making. The gray is when women can decide on themselves. The yellow is when she decides together with the husband or sometimes the mother-in-law. The blue is when the partner decides, or sometimes the mother-in-law. And the orange is when somebody else decides. Sometimes it's even outside the family, somebody who decides. So you see here the huge differences. In Slovak Republic, there 73% of the women can decide on their own. But if you see in Bangladesh, it's only 3%. So you see huge differences in decision making, and this is very important because a lot of the community sensitization that is taking place in the world is focusing on women only. And women are explained about the importance of going to screening for cervical cancer, but this means that in many countries we must shift our focus, and our health literacy activities must not only focus on the persons who are directly involved, the women, but also on the family members who decide. So here I have put some important lessons learned, so that we need to really analyze the health literacy status well before we start community mobilization. We must know the knowledge levels, how well they are, and within a country or within a target population, we need to know the people with low health literacy so that we can adapt our messages and make sure that they are all covered. And we did find huge differences in knowledge per country, but not so much difference between women and men. So even when women know a bit more, then still husbands are more or less at the same level. So apparently they share their knowledge in the household. So if men are not knowing enough, we need to involve them. And so what we also found is that women who are dependent on others to decide have less knowledge compared to women who can decide. And so if we find in a culture where decision making on health issues is very much dependent on mothers-in-law or husbands, we really need to address the knowledge levels of all the family members. And another important lesson that we learn is that if we do health education, the knowledge on screening increases. But after 1 year, the knowledge level goes down again. And that is very important because in cervical cancer screening, the women who have an HPV infection must be rescreened after 1 year. And we did find that after 1 year, you have to start all over again in health education. So if you do health education before the start of screening, you cannot assume that that knowledge will stay forever. Much of the knowledge disappears again. Women and men forget the knowledge they had about cervical cancer. So we are here in a seminar about health literacy. So our advice based on our experiences in the cervical cancer project is to make an assessment of health literacy levels before you start with an intervention, so that you know where are the populations and target groups that have the lowest level of health literacy, because those need special attention. Then you must be aware of decision-making structures in the family. So if you increase the health literacy levels of women only, and they don't have decision power, you will not achieve your goal of providing screening or some other health service. You must really involve the decision makers in your health literacy efforts. And the last point is that health literacy should not be a one-off activity. And the increase of health literacy is a process, and you must continue doing that over time in order to achieve better health for women and their families. Thank you very much for your attention, and I give now the floor to my colleague, Dr. Arti, who will explain more about the situation in India. And if you have any questions, please put them in the chat, and then we can answer that. Thank you very much.
Thank you so much, Yap. I hope I'm audible.
Yes.
Can people hear me? Yeah. Okay. Thank you so much. So just taking upon where you left, two clarifications and also a little bit about the Indian scenario. So just it was a multi-country project, and when it was Bangladesh, Uganda, and Slovakia, it was one set of population more or less, which was being with a lot of similar characteristics like the camps or the project area. The population for that from which a sample is taken was sort of relatively similar, I can say. But however, in India, we ourselves were like sort of a mini consortium. So when we submitted this application for the project with 4 centers, 3 more were added, which was socio-economically more dissimilar to the 4 centers we had applied, so that it is more representative, because we all know that India is a very diverse country, and so that is the reason like it was added. And so we are 7 sites. MAHE was in the driver's seat because the IPR, intellectual property rights for the artificial intelligence, belong to MAHE. And so we led the consortium, and the other partners were we had a College of Ayurveda in Udyavara from the same state. From Karnataka, we were 3 partners, and the other one was St. John's Research Institute from Bangalore. And then we also had the Tata Medical Hospital in Mumbai, TMH Mumbai, Tata Medical Center from Kolkata. We also had the Chittaranjan National Cancer Research Institute from Kolkata, and our own sister concern, which is Sikkim Manipal University. So we were along from the Arabian Sea to the Bay of Bengal, representative of the south, west, and the eastern parts of the country, which represent quite a bit of a population of the country, and that's how this consortium was formed. A little bit where to add to what Yap said, the awareness course, like you saw that it was 38% in India compared to the other countries, which was 71% in Uganda and Bangladesh, as high as 81%. So, but what happens is, once your population is more, the India is the most populous country, I can safely say. I think we have overtaken China also. And given the diversity and given the denominators, what we have, obviously these will, fall. That is one of our observation. Of course, in India, the project is still continuing, and we are going to wind up by November 2024. and we are still in the process of data collection, and this is the initial insights what we can give from the field and our viewpoints as far as the data how it looks, that is concerned, the prevalence scores, and also like the 2% prevalence and the 38% prevalence and the scoring of 2. So I personally believe that when all the 7 consortiums representing the diverse settings and we would take an average like this, overall average, this is how it's going to look. Perhaps we have to do some sort of a subgroup analysis, because you see the size of Uganda, you see the size of Slovakia. I think it is similar to one state within India, and that's how it looks like. And perhaps we should attempt some more subgroup analysis, because ultimately all of us are working towards cervical cancer elimination goal. We work on the premise that whether it is Uganda, Bangladesh, Slovakia, or India, cervical cancer is cervical cancer. But we need to see what are those factors which take a primary role in each of these settings across the globe, so that all of us put our efforts together, so that we work together towards elimination of cervical cancer. And I'm very happy when Yap said that eradication of HPV is such a big dream for all the public health and global health specialists, and I hope we live to that day to see that happening. And the other thing which I wanted to add here was that the decision-making process. So when put this pie charts, for the 4 countries, we saw that there's a lot of similarities between Bangladesh and India. So between Bangladesh and India, because I feel that culturally, socio-culturally, and socio-economically, we sort of somewhat similar in extent to the Asian countries, unlike the decision made by partners and others making decisions, and all sort of dissimilar compared to Uganda and Slovakia. So maybe that could be another added dimension for the analysis of this multi-country project of Prescriptech, which can give some cues towards steps that can be taken for cervical cancer elimination. So where Yap stopped, I thought that I'm going to take it up as far as the knowledge level is concerned. I'm watching time. I don't want to exceed and take another people's time. So I wanted to add, I need to share my screen, so someone has to unshare. I think Yap, you have to unshare. Yeah, thank you. So from where Yap left, so I wanted to talk about the knowledge and the sustenance of knowledge. So just wondering to myself where we can both work, speak together as far as the cervical cancer elimination is concerned. So I made a small deck like this. So what he said was one of the factors we need to consider is the awareness levels, and of the community, of the women who have to take the self-swab, and also the partners, what is the role of families and other influencers, and the importance of that awareness. And the second part, what he said was, how can we sustain? Because after 1 year it was relatively low in those places. So sustenance of measures. I was wondering to myself, what can be those factors which could play towards awareness, sustenance of this awareness. And then what hit me was that, let us see about this HPV cell sampling, what's happening in the diverse setting like India. And we just went through a literature search, and this information we got, which could work on perhaps even recommendations. Because for the prescriptive project also, what we have done in level 1 is that, or phase 1 is that HPV cell swab test, because it has shown, literature has shown, evidence has shown that it is highly sensitive and comparably sensitive and specific compared to the other endocervical swabs that is being taken for screening for cervical cancer. Is my screen visible? Can people see my screen?
Yes,
Yes,
ma'am.
ma'am. Yes, ma'am.
Yes.
Yes, ma'am.
Yeah.
Thank you. Thank you. So I have titled my talk as The Pandemic Influence on the HPV Cell Swab Test and in Indian Experience. What I tried to see through the literature was, what was the uptake of this this vaginal swab, HPV cell swab test prior to the pandemic, and what is post-pandemic, how it has really changed. So when we heard from Yap that after 1 year the knowledge is comparatively reduced of cervical cancer, then what is the attitude towards the cell swab? I was interested to know, and then perhaps we could sort of get an idea about the sustenance of health literacy in the population towards cell swab, which is definitely important as far as this is concerned. So when we skimmed through the literature, what we saw through these various articles is this Preventive Oncology International, it has established that self-collection could be equivalent to direct endocervical sample. So this was basically, we got from this article, which was a study done by Bellinson Jail and Pretorius RJ. They published this as a brief history of HPV self-collected vaginal specimens for cervical cancer screening. in gynecological and obstetrics in 2023, that is last year. So what they said was it was established in 2004 to 2006 itself, and this was done by the Beijing Cancer Institute in a selected population of China, because those were the days when China was the most populous country and what they could be thinking. This was again substantiated in a large randomized trial with over 10,000 participants, which confirmed that self-collected vaginal specimens for high-risk HPV using PCR assay could replace endocervical specimens with a comparable sensitivity and specificity. In 2013, the World Health Organization recommended HPV cell swabbing as an option for initial screening. So what happened next? So what was happening within India, if this is what was happening in China, the next populous country? So before the pandemic, So before the pandemic, the HPV cell swab was already explored in India. And then there was this study that was conducted by Bansal, Wittet, and Winkler et al. Regarding acceptability of cells collection sampling for HPV DNA in low resources setting, which was a combination of India, Uganda, and what I've taken is some of the data pertaining to India. So in India, 78% of the women preferred self sampling. Okay, and then this was as early as in 2014. And we don't know, it was not explored whether because it was a matter of convenience or it was a matter of privacy. Well, however, even though they preferred self-sampling, 54% expressed concern. This was a mixed method study, a combination of quantitative and qualitative. So there was in-depth interviews conducted among a selected sample of women who expressed 54% expressed concern about hurting themselves during the process, and 24% were worried whether they would be able to get an adequate sample, which is again corroborated by these verbatims that was posted in the literature. So I prefer the medical person to do the sampling because she will see where she is inserting, because it was a blind thing if they did a self swab. Everything was fine, but don't want to do it by myself. Somehow they was a bit shaky about it, and these were the verbatims from the Indian participants. So self-sampling acceptability was higher after educating the women, and these were some of the measures they introduced during the course of the study, like education of the women, staff help because they preferred staff, better pictures, when they were doing the IEC, information, education, communication, and also if they were provided a chance to practice this swab, because already you can see the study says 78% preferred self-sampling, so this was not a problem at all for them. Of course, when you want to do self-practice and all these things, you need to have abundant money and funding, because one swab, second swab fails or something like that, so you have to give them some sort of a repeated chance to practice. So that is something, resources which you have to be on your side to do such kind of studies. There was another study that was done in rural South India in Mysore, which was conducted by Purnima Madhivanan et al. On acceptability and concordance of self versus clinician sampling for HPV testing among rural South Indian women, which was published in 2021. And what they reported was in the rural women showed better acceptability, close to almost 60% of self sampling, with women rating significantly higher than clinical sampling for comfort and privacy. So they rated comfort and privacy. That means that we can see that the acceptability for this process of self-sampling was relatively higher even among the rural women, and this has been published in 2021. So what has been there, if this was in the pre-pandemic, then what happened in the post-pandemic scenario? So the pandemic, of course, we all know that it slowed the non-urgent services, including cervical cancer screening. There were more burning issues with the lockdown, with accessibility being a huge problem, and everybody, there was a fear of death and anxiety, and visit to health centers was completely no from the population. So that was more emphasizing for self-sampling. A shift towards self-sampling during the pandemic trend continues, and it has increased during the post-pandemic. The success of the HPV self swab depends upon creating effective health education materials and understanding the methods to raise awareness. There was a study that was conducted by Anand KV and Gauravi Mishra, Sharmila Pimple. So Gauravi Mishra and Sharmila Pimple are from TMH Mumbai, who are also partners in the present prescriptive consortium. But they had another funded study, which they have reported a cross-section study of HPV self-sampling among the Indian women and what is the way forward. So what they said was in this study, which they conducted in Mumbai, in the Maharashtra state, they said that the acceptance was 100% in women who received health education and 94% who received pamphlet. So there were two arms for this study, which was the health education arm and the pamphlet arm. In the health education arm, the health personnel explained risk factors, types, benefits. I'll just take 2 more minutes. risk factors, types, benefits, and steps of the process in local language, but they were the health professionals who did that. And the other arm was participants were receiving pamphlets with pictorial instructions for the steps of self-sampling. An agreement between the HPV self-sampling and also the primary health worker sampling, it was demonstrated to be close to 95.1%, and the results of the pamphlet arm were comparable to the health education arm in every respect in this particular study. There's another study that was conducted in Maharashtra by Wahabi et al. In 2023 among rural and tribal women, and 96% they adopted a thing called as she's sexual health education, and following that, providing the education, they took this they wanted to assess the HPV self-sampling patterns among these rural and tribal women, and also men were engaged through education sessions, delivering information in the form of storytelling and using art-based sexual health education. So we say tribal women, rural women, so we need to connect to them in the ways they can understand better. So there was a demonstration video, there was a matinee movie related to cervical cancer, testimonials from doctors and cancer survivors, etc. They were all adopted as a form of as a part of this sexual health education, and they found that there was enhanced literacy and improved screening uptake in this particular population. So another study by Bose et al. In 2023, last year in Kolkata, they published in 2023, but the study was between April 2020 to February 2023. A total of 10,792 women underwent screening using the self-sampling alone, and they showed there was an indicating towards a shift towards this method. Of course, in this particular project, they had done the door-to-door awareness, and it was given to rural and semi-urban women to improve their awareness to undergo screening. I think this is my last slide. So what I meant to say through my this short and quick presentation is that even though the pandemic is sort of subsided, I don't say it's completely over, but the sustenance of knowledge is there, the uptake of self-swab is there, and we need to check through our qualitative interview in this, across the consortium, the partners, all the partners have done their qualitative interviews with the women, and with those who are very positive, they have done the focus group discussions among the healthcare providers and the healthcare personnel who facilitated this particular topic to see what were those factors where the self-swab. Our personal experience in Manipal, in our sample size of 1,000, of course, it's very meager to compare to the populations what we have, but we said that when we ask them questions like, this HPV self-swab is just for 5 years, and this is a project-based camp, and now it is free of cost, and if you have to repeat yourself after 5 years, which is of course required for your sustenance of HPV-free life, they said they won't mind, So that is the thing they say, as per even with the cost, as well as to undergo this vaginal swab and self swab in the comforts of their home. So our data analysis is still in progress. We don't know the final shape, but it was a very positive and rewarding experience to interact with these women during this project. So I stop here, and thank you very much for the organizers for giving me this opportunity.
Thank you, ma'am.
I'll just
Yes,
yeah
ma'am.
yeah I'll just unshare.
Yeah.
Thank you.
Thank you, sir and ma'am, for sharing your valuable insights on the topic. Any questions will be taken up during the final discussion later. Now I would like to welcome our next speaker, Dr. Vijaya Raghavan, a distinguished psychiatrist who graduated from the Institute of Mental Health at Madras Medical College, Chennai. Since 2015, he has been associated with Schizophrenia Research Foundation, SCARF, in Chennai, where he serves as the consultant psychiatrist in research and heads the Department of Youth Mental Health. He is also an adjunct faculty member at the ICMR National Institute of Epidemiology, NIE, Chennai. Dr. Raghavan engages in clinical practice, community outreach, training, and research activities. He has been honored with prestigious fellowships, including the Fogarty and PRIIA Fellowship in the USA, the Commonwealth Fellowship in the UK, and the Nurturing Clinical Scientist Fellowship in India. His research interests lie in youth mental health, early interventions, and community-based interventions. Dr. Raghavan has made significant contributions to the field with 92 publications in international and national journals and involvement in numerous research projects. Let's warmly welcome Dr. Vijaya Raghavan as our second speaker.
Hi, everyone. Thanks a lot. I'll just share my screen. Are you able to see my screen? Are you able to see my screen?
No, sir.
Right now? Okay. I have some difficulty sharing screen, I guess. Are you able to see my screen right now?
No, sir. No, sir. No. Sir.
Now?
Yes, sir. Yes.
Yes.
Perfect. Perfect. Thanks, everyone. I must first thank the organizers for giving me an opportunity to talk about youth mental health, especially from Schizophrenia Research Foundation, our organization side. It's a pleasure to be here, and I'm really glad that I can hear such great talks from the previous speakers. So I'm going to talk about youth mental health, especially from the institution, Schizophrenia Research Foundation perspective. And I'm going to give some details about the research that we have done in perspectives about youth mental health literacy as such. But before that, I will cover a bit about our organization, the department, so that you will have some groundings on what we are trying to do. And then I'll talk about the research findings, and then can have a good discussion about how we can go about from there. So, Schizophrenia Research Foundation, SCAF, this is a not-for-profit organization. It is in Chennai, India. It's a WHO collaborating site for mental health research and training. And we do a lot of activities ranging from clinical services, research, outreach, and advocacy. Especially in the clinical services, we are divided into three big departments in a sense. One, the Department of Youth Mental Health, which ranges from 10 to 24 years of age. The adult psychiatry from 25 to 60, and the old age psychiatry more than 60 years of age. And we have been in the fort for the past 40 years, and glad that we are in the 40th year and we are celebrating that. Thanks to us. And coming to the youth mental health, initially there was no Department of Youth Mental Health SCAF, but we started with research projects working on youth mental health. In that, what we saw was that most of the mental health issues among the adults start very early, especially between the 10 to 25 years, 10 to 25 years of age. So we wanted to concentrate on in this age group on various grounds, especially on promoting mental health, identifying early access to services, because all these things have impact on how we will be able to overcome the illness as such, and also how this is going to have an impact on the outcomes of the disorder as such. So we wanted to work on these things, and also we did a kind of a survey among 15,000 young people in schools and colleges in Chennai, where we found that the prevalence of depression and anxiety among the young people is around 30% and 21%, which is quite high. And what we are talking about here is a moderate to severe depression and moderate to severe anxiety. At the same time, we are also found that psychotic-like experiences are also quite high in the age group between 10 to 24 years of age in Chennai, especially in the educational institutions. These two things pushed us to think a lot about whether we need to have a separate department so that we will be able to concentrate on that. And we started a department, and lucky that we are the one of the kind of first departments in India to have dedicated for youth mental health itself. And it all started as a program because we did a lot of research on youth mental health, and we established as a program in department in 2022. And as I said, 10 to 24 years of age, and we do a lot of activities like clinical research, outreach, and capacity building. And initially we started with a model that we wanted to work specifically on youth as the base, because without that we are not going to go anywhere. Here when I say youth in all settings, where we are trying to empower youth and also involve youth in all the activities that we are doing as a department at SCAF. And also we wanted to work with families and communities, and academic institutions and workplaces are really important, because these are kind of a institutions where we will be able to go there and improve mental health, promote mental health, give awareness, improve literacy, and also you can give interventions, follow them up and see how they are improving. And also these institutions are also really important because they could be a conduit and from which people who are having issues can be brought to the mental health services quite quickly. At the same time, we also felt that psychiatrists, psychologists, social workers would not be able to cover all the young people in all different settings. It is really important to bring in health professionals from other departments like pediatrics, community medicine, and train them so that they will be able to provide the first point of contact, and they will be able to stream or treat some of the persons who are having mental health
Sorry to
issues.
interrupt, sir, but we can't see your slide. I think you've not shared it.
Okay, right, you are not able to see my screen?
We are able to see your screen, but you have to share the slide as well, the presentation.
I am presenting. Are you able to see now?
No, sir.
I'm sorry, I'm not sure what to do right now.
So can we shall share your slide. We have it with us.
I already sent it to the Manipal
Yes,
mail
yes,
ID.
yes, yes.
It's
We'll be sharing from our account.
amazing. That would be really great. Thank you. I will stop my.
Is it visible, sir?
Yes, thank you.
Kindly tell me which slide do you want us to be on?
Okay, we can just keep moving. Yeah, that would be.
Thank you.
Thank you. Apologies for the technical glitch. I'm really sorry. So what we wanted to do was we wanted to have a public health approach in working with the department as such, and we try to have different levels, different tiers, where we will be able to work with all quarters of people in working with young people and try to promote mental health or early identification and prevention of mental health issues among young people, and early identification, access to care, and at the end would be the tertiary care. Next slide, please. Uh, can we move to the next slide? Perfect.
Yes, sir.
Perfect. Thank you. First, what we did was to make sure that we have a kind of a conducive environment. We did a qualitative research with young people who are using the services, and to understand them, what are the most important principles or philosophies in which the whole department should be built on. Whatever service that we are trying to build or provide to the young people, we we identified that it should be comprehensive, innovative, inclusive, participatory, and accessible. And this was done by one of the research assistants, Helen from SCARF. And one of the important things that has emerged is a participatory approach. It is really important that whenever we work with young people, it should be very participatory so that they are involved in all aspects of the services from the scratch, like what kind of services, what time it should be provided, what are the things must be provided. It is not only for the research, also we are also involved. It should be involved that they should be in the research aspects and whatever the research that we are trying. Next slide, please. So whenever we try to design anything, we use this kind of a participatory design where we have an inquiry from the young people that what it should be done or not, and social aspects like the education, economic status would be considered, and we would be involving the young people in all the process, and we would be co-designing with them in all the activities. Next slide, please. Perfect. Thank you. So for this, what we initially did was that we developed advisory boards at the start of the department itself. We have two advisory boards, one for the first episode psychosis and for the youth mental health, where these are people with lived experience and also who are working from the angle of mental health. Some of them are psychiatrists, psychologists, and social workers. We are all as a team come together, and whenever we are developing a service or evaluating the service, we work with them to make sure that we get insights and also work towards the suggestions and inputs they provided. Next slide, please. And especially post-COVID, there is a kind of a drastic increase in the number of young people actually seeking help for mental health issues. And COVID itself has highlighted the importance of mental health, and this has really picked up. And we can see that there is kind of a increasing trend in young people seeking services from the OPDs in SCARF. Next slide, please. So from the research angle, we have been trying to do a lot of research activities. There are most of them are international studies, especially with UK, and some of them are with Africa. And most of the things are in the direction of assessing the mental health awareness among young people, improving the mental health literacy, or interventions to improve their cognitive status or coping skills. And also we work with, some of them are working in the angle of special situations, like for example, young people who are in the juvenile justice system, and especially we also work with intergenerational conflict among young people and parents. And in the JPAL project, interestingly, we are trying to work with how economic incentives will be able to improve young people accessing care for mental health issues. And in NS project, we developed a mobile phone application where it will be a one-stop solution where mental health literacy will be provided through that, whether people will be able to screen for mental health issues, and also they will be able to access peer support through the app itself. These are some of the research that we are trying to do right now. Next slide, please. And one of the important things that we have developed is the youth safe space. Here it is actually a separate space, a separate home in a sense, where young people can come together, talk about their mental health issues, not only about mental health issues, they can also talk about other aspects in life. They decide upon what topic to be discussed, how it should be discussed, and we as mental health professionals will be passive observers rather than doing anything active. And it's such a democratic place, and also it is non-judgmental, and any people can drop in at any point in time and have discussions, or even if they want to just sit around and work among themselves, they can do that. Next slide, please. Next slide, please. Thank you. This is just the rhyme space. And to coming mental health literacy among youth and stakeholders. Next slide, please. One of the things that we initially discussed and identified was that it is really important to make sure that arts as a vehicle to improve mental health literacy among young people. And we also found that it is not only for young people. Whenever we are trying to talk about mental health concepts and or anything that we want to impart among the other people, like community-based organizations, arts has been really important to us and really helped us to drive down the important information that we want to provide them. Next slide, please. We also use a similar kind of a methodology to work with mental health professionals. We have a separate program called C2C, which is clinic to community, because especially when it comes to youth mental health, it is really important that mental health professionals are trained to work with community-based organizations, community institutions as such, and young people in the institution, so that they will be able to know how to deal with them, how to speak with them, how to interact with them, so that they will be able to deliver mental health interventions or literacy programs much better. Next slide, please. I'm going to talk about some of the research that we have done in our settings and what are the findings, especially from the mental health literacy point of view in the youth mental health itself. The first thing what we wanted to understand was what it means by youth mental health for young people or mental well-being. We understood that this was done among young people in Chennai in different settings, schools, colleges, slum settings, and also workspaces. What we understood was that the concept of well-being or mental well-being itself is really poorly understood, and also the mental health concepts about mental health itself is like it's having a good time with friends or having good sleep. Even though these are components of mental health, a good mental health, it is have a kind of a reductionistic view about mental health itself. Next slide, please. And one of the important things that emerged during these interviews was that young people listen to young people. Whenever we try to impart mental health literacy or mental health interventions as such to the young people, especially in the schools and colleges, they expect young people to come and deliver these things because they think that they will be able to, or they think that they are able to identify themselves much better with them and able to discuss the issues with them rather than with older adults. So we took that as a really important aspect, and we try to build most of the mental health interventions, even it is literacy programs or interventions, are delivered through young people itself, training them, making them ambassadors, and they are delivering the mental health literacy. Next slide, please. We did that in India, and then we wanted to see that this some similar kind of a picture is there in Africa. Also, we did a kind of a larger study in India, South Africa, Rwanda, and Kenya, and try to understand what it means by mental health among young people and what are the usual actors and channels young people engage with whenever they are trying to understand mental health or they want to learn about mental health literacy as such. We can see that most of the ideas about mental health are quite common among all the settings, and we can see that peers and friends are the most important young people reach to ask about mental health itself, and then comes the close family members. Next slide, please. And we did a stakeholders perspective about youth mental health in India, where we engaged with different stakeholders from Tamil Nadu and New Delhi. And we understood that, and we had participants from young people, teachers, parents, and also policy makers. we understood that from the parents, it's really difficult for them to have knowledge about what is normal and what is abnormal among teenage. And also it's really, people are not aware about mental health itself, and also they also do not know where to get the appropriate or authentic mental health informations for them. And some of the recommendations that has emerged where it is really important to build mental health as a curriculum within schools and colleges, so that they will be able to learn that over a period in time, and also provide it in a structured way, and also use social media in appropriate way, so that they will be able to gain information about mental health as such. Next, please. In one another study, it's a pre-post study where we developed a mental health intervention to improve literacy among young people, um, where we found that most of the young people had knowledge and behavior towards mental health in an appropriate way. But after the intervention, there was definitely an increase in the mental health knowledge and stigma towards it. But after over a period in time, after the intervention, after 3 months and 6 months, there's kind of a quite decline in the knowledge and stigma towards mental health among the young people. Next slide, please. And we did an RCT among young people, where we divided the group into two groups. One provided only mental health literacy, and another group was provided mental health literacy with contact-based education, where young people with lived mental health experiences were introduced to the young people and discussed about their issues and how they tried to overcome from that. In this, what we understood was that both the groups had very similar kind of a knowledge gain after the end of the sessions, but people who are exposed to contact-based education were had a much more positive attitude change towards mental health itself. Next slide, please. And the most important challenge that we are observing these days is that even though we are improving the mental health literacy and we are seeing some changes among young people, it is really young people are not turning towards taking help. There is less access to care, especially from the services, not only from the mental health services, but also from school counselors or college counselors at the end of the day. It is really important that, because it is really important we move from not only from improving mental health literacy, somehow we have to make sure that there is a behavioral change and people are able to actually take up these things and able to use the knowledge and take the appropriate help. We can see that there are various challenges or barriers in accessing that, because it can be stigma, misinformation, limited access, and peer influence and social norms. Next slide, please. Can we go to the next slide, please? Next slide, please. Yes. This is the last slide, and what we can see is that there are, it is from the previous presentations and also this, what I observe is that there are some common themes, like how to make sure that mental health literacy or health literacy is transformed into actionable points or actionable behaviors. And I think it is really important that we can all discuss together and see how we will be able to overcome that. I think the principles can be much more common, and definitely we will be able to take that up and use that in our own settings and see how we will be able to take it forward. Thanks everyone for listening to this, and I'm really happy to take if there are any questions. Thanks. And thanks for helping me sharing this PPT. I really appreciate that. Thanks.
Thank you all for sharing such valuable insights. It is truly inspiring to learn about incredible work you are doing and the impact it is having. So we would like to move forward with the panel discussion. We have a few questions from the participants in the chat box. So my first question will be to Dr. Koot. How can culturally sensitive health education be tailored to improve cervical cancer screening uptake?
Thank you. Thank you, Dr. Raghavan, for your introduction, because while you were talking, I was really also surprised about the similarities between youth mental health and cervical cancer screening, though in terms of medical terms it looks far apart, but you look at the very same issues of accessibility to care and acceptability. Because you increase knowledge on mental health, but that doesn't mean that now the youth are coming to the clinics, maybe they find still that they are stigmatized, or they find people that they don't trust. So the cultural sensitivity is not only for cervical cancer, but across the board for acceptability of the services. So what is very important is to make a good analysis, like you did for mental health issues and so on. So culturally sensitive, like the peer support. What we found is that community health workers who are trusted women in the community, who are the neighbors more or less of women, are much better placed to do the health education, the peer education, than when a professor from a university comes to tell women what they should do. So that is very important at looking at the local culture. One other example that we had is we know that HPV is a virus infection that is sexually transmitted. But if you present to women this as a sexually transmitted disease, then it will stigmatized. So what we say, it is a virus that is everywhere in the world and affects 90% of the women and men. So it is not a shame to be infected. So you really must then not put an emphasis on sexually transmitted diseases, but on the fact that it is a virus that is everywhere. So you must look at those kinds. So proper analysis is very important, and also looking at the kind of message you give, but also who conveys the message. And often we see that we as academics are not the best ones to give health education. And also, if you are in a consulting room, when I as a doctor say to a patient, you should stop smoking, doesn't work like that. You should have others who do it. So cultural sensitivity is the crucial for health literacy, and we should look further away from our academic settings to see who are the best ones to be involved in the health education. Thank you.
Thank you so much, sir. My next question is to Dr. Raghavan.
Maybe Dr. Raghavan can answer this also from his perspective.
Thanks, Professor Good. I think what you said was really good. The most important thing is that there is no need that professors or clinicians should be doing everything. Here, there's kind of a pressure for people that only a clinician should do everything. I think it is really important that we have to diversify and also respectfully involve other people. Sometimes what happens is that here, especially sometimes a clinician or a doctor takes up preponderance and say other persons would be instructed to do certain things rather than you involve them more collaboratively. And when you said that we sometimes assume that we know everything and try to say that we know how to provide the mental health literacy or knowledge or mental health other aspects, but in a sense it is not so. So it is really important that, but it is also sometimes very difficult to bring in all kind of players as one team and try to provide that. And maybe this kind of a question that I should ask you at some point in time, that how you are envisioning that different sets of people who are different calibers and different expertise come together as a team to provide improve mental health literacy as such, or any health literacy as such, because sometimes it's quite difficult to work with diverse group of people also. But if at all you have any kind of an experience in this direction, it would be really great. The first thing is that. The second thing is that what you said was really great, that again trying to use local resources, because these are very closer to the communities, already trusted, and it is really, there is no need that I should be going and starting a new campaign within an organization or community, but work with other community based organizations already in the field, piggyback on them, use their trust, and provide mental health literacy to the communities that they're already working on. I think these are all but sometimes it's really difficult to actually do. I mean, that's what the whole hard part is, I guess. Thanks.
Thank you so much, sir. Our next question is to Dr. Raghavan. How can we use technology such as mental health applications or telemedicine services to provide mental health services to the youth?
Okay. Thanks for the question. We have this telepsychiatry and app-based interventions are still in infancy in India. I would say we may around the world also. We do have, when we go to the app store or a play store, we see a lot of apps to improve mental health or interventions and such. But we do not have a very few apps has been systematically studied and RCTs has been done to make sure the efficacy of it. But there's kind of an unregulated applications available out there, and it is we cannot blame the young people because they just take up whatever that is available, but it is also somehow important to regulate certain aspects of it so that uh, the tested ones are available for use. That's one thing. The second thing is that especially post COVID, there is kind of an increase in the uptake of telepsychiatry services as such, and we will be able to harness that. But what in a recent one of the interviews with young people, what we understood was that even though there is kind of an inclination towards using telepsychiatry, many of the young people want to have face-to-face interactions because they see that more humane and also able to communicate better, and also it gives them a lot of scope of discussing in person, and improvement wise also they feel that they are much more better when they are facing face to face. But from a very public health perspective, yes, especially telepsychiatry services are picking up, especially Nimhans is doing a lot of other aspects on that. I think we can explore that, but still, as I said, some of the aspects might not be able to be provided by telepsychiatry. Technology wise, yes, apps are one aspect of it, but again, as I said, it is really important to test these apps, build apps with all appropriate experts together, and then try to test it through rigorous scientific process, and then try to make them available in the open market so that people will be able to use it for right senses. Thanks.
Thank you so much, sir. It has been a wonderful discussion. And yeah, I'd like to thank everyone who has helped in making this webinar a successful one. And I extend a heartfelt thanks to Dr. Sharian Burgess, Director of Prasanna School of Public Health, and MAHE Press, Media Administration, and all the support we have received. I have not mentioned the names, but thanks to everyone who contributed to this webinar. Yeah.
Thank you.
Yeah, we can now conclude this meeting.
Perfect.
Thank you very much. Yeah.
It's a
Thank you
pleasure
for
meeting
organizing.
everyone.
Yeah. Goodbye.
Bye.
Bye bye. Yeah.